Guys, I'm just going to go over my review for my second pharmacology exam. It's just a little something I've put together. I don't really expect anyone to watch this. Like I said, like the last one, this is mostly for me. So I can go back at the end of my quarter and review these for my HESI. So here it goes. Well, I guess I said I'm going to talk about diabetic drugs, stuff for heart, cardiac drugs, and some antiemetics and stuff like that. So let's get started. Okay, first, hypothyroidism versus hyperthyroidism. Drugs to treat hypothyroid, which would be Synthroid. Signs and symptoms of hypothyroid: tired, sleepy, slow metabolism. Sorry, I'm tired. Bradycardia, Graves' disease, which is your hyperactive thyroid. You treat this with PTU and tapazole. Signs and symptoms would be irritability, sweaty, tachycardia. You're going to want to watch for thyroid storms. And these patients might be put on beta blockers. If they ask why, you want to tell them, well, this will decrease your cardiac pressure, which will help you. Hypothyroid drugs, you're going to want to take the meds 30 minutes before breakfast. Hyperthyroid, which is PTU and tapazole, can cause liver disease, so you're not going to want to give these long term. You're going to want to take their labs every 3 months. Like I said, it's not for extended use. What is a thyroid storm? A thyroid storm, you have a fever, high blood pressure, you're severely tachycardic. Okay, now let's talk about some diabetic drugs. Diabetes. Type 1 diabetes means you're insulin dependent. Type 2 diabetes is, you can treat that with oral medications. If the oral medications aren't doing what you want them to do, you might use a sliding scale. You're going to want to check their blood sugar before meals. Never drink your insulin. It doesn't work that way. You always have to get sub-Q. You're going to want to give it in the fatty areas for rapid absorption. A type 1 insulin pump, that just contains regular insulin. Type 2, like I said, it's oral anti-diabetic medication. You could use a sliding scale, check blood sugar before meals. Signs and symptoms of hypoglycemia. You're lethargic, clammy, you're jittery. Hyperglycemia, signs and symptoms, confusion, the 3 Ps, polydipsia, polyphagia, and polyuria. Patient teaching for that. You're going to want to show the family members how to administer glucagon, how to take the blood sugar, and what to watch for as far as signs and symptoms of hypo and hyperglycemia. Now let's talk about some insulin. A fast-acting insulin would be Lispro. Lispro kicks in within 5 to 15 minutes, so it's got a very fast onset. So your nursing intervention for Lispro would be that you want the food in front of your patient before you give it. Your patient on glucophage. With glucophage, you're going to want to make sure you stop taking it 24 to 48 hours before any scans, especially PET scans, PET scans, because it will cause false readings. Now, if you take them off and you make them PTO, don't give them dextrose. For patients with DKA, which is severely high blood sugar, I'm talking like 600, 700, 800 off the chart blood sugar, they're going to be very confused, and you're going to want to watch for fruity breath. That will give it away immediately. You want to send them to the ICU. They're going to give them insulin in an IV. It's going to be just regular insulin. Your nursing intervention, you're going to want to check their blood sugar every hour. For your patient on steroids, watch for steroid-induced diabetes. When the steroids stop, the diabetes will go away. It's kind of like gestational diabetes, but you're definitely going to want to watch your COPD patients. And also type 2 diabetes, patients can be asymptomatic. Even if their blood sugar's through the roof, they're not even going to notice. Okay, Addison's disease and Cushing's. Addison's is hypocortisol. They're at risk for fluid electrolyte deficit. You're going to want for arrhythmias and watch their blood pressure. Addison's can be fatal if left untreated. Cushing's, which would be too much cortisol, that's too much fluid and electrolytes, and you're going to want to treat these with glucocorticoids such as Florinef. Okay, on to cardiac. Heart failure. Right-sided heart failure, you're going to see peripheral edema. Left-sided heart failure, it's when you're going to start to see the big dog stuff come out. Pulmonary edema, congestion, wet, crackly lung sounds, shortness of breath. If patient has left-sided heart failure, they're at risk for right-sided heart failure as well. You're going to want to treat that heart failure with DIG, and you're going to want to hold that DIG if the heart rate's under 60. So teach the patient how to take their pulse. If their levels are over 2.5, that's DIG toxicity. Signs and symptoms of DIG toxicity is bradycardia, nausea, confusion. They're going to see halos around things. You're going to want to get lab values to test for the toxicity. The antidote to DIG is Digivine, and the half-life of DIG is 36 to 40 hours. Okay, looks like I'm going down to non-pharmaceutical measures. Watch your sodium intake. You want to take less than 1 teaspoon per day. Make sure your patient's getting proper rest, decrease stress if possible. Avoid extreme weather changes. Teach patient to deal with things therapeutically if possible. How do you treat angina? Angina is treated with beta blockers. Beta blockers, aka LOL drugs. Stable angina is angina that's only brought on by stress. Propranolol is an example of... Oh, I'm so sorry, I've been so tired. Is an example of a beta blocker. Not for patients with lung disease because it is not cardiac specific, so it's not just going to affect the heart, it's going to get your lungs too. And you really don't want, lung disease patients to have bronchospasms and everything else. And for your unstable angina, you're going to want to treat those with nitrates. Some examples of nitrates are isosorbide and nitro. These both cause massive vasodilation. It's going to decrease your blood pressure, so make sure you're watching for orthostatic hypotension. Your patient will feel weak and have a headache. Now, variant angina is treated with calcium channel blockers, for example, cardizem. Cardizem is also for patients with AFib. You're going to want to watch the orthostatic hypotension with that as well. And this is not for patients with second or third degree heart block. Never give it to them. Nitro, you're going to give that every 5 minutes, 3 times. If there is no improvement, you call 911. Nitro is stored in a little brown bottle. Make sure it's sealed. Always check for expiration dates. And you're going to want to keep it out of the sunlight. Hypertension. Some non-pharmaceutical ways to treat it is decrease your sodium intake and exercise. There are 4 different types of hypertensive drugs, and you're going to want to treat your hypertension sometimes with diuretics or hypertensives. The 4 types are loop, thiazide, osmotics, and potassium sparing. Loop diuretics are like Lasix or Bumex. They work quick. They're more for acute crisis. They're going to diurese you really, really fast. A thiazide like HCTZ, that's more of a maintenance or a long-term drug. Be careful with your diabetics because they could cause hyperglycemia. Watch your glucose levels with them. And osmotics such as mannitol, this is given to decrease intracranial pressure. And for cerebral edema, you're going to know it's working if their level of consciousness increases. And there are also potassium-sparing drugs. I didn't write an example of that down. I'm going to have to look that up. Anyways, watch your potassium intake. Watch your potassium levels. We're almost done. For patients on diuretics, you're going to want to watch for electrolyte imbalance. Monitor their kidney function and blood pressure. And make sure there's no heart block present. ACE inhibitors, Watch potassium and sodium. You're going to want to use herbs for seasoning. A side effect of an ACE inhibitor would be a nagging cough. If you get the nagging cough, you're going to want to switch to an ARB drug. And ACE inhibitors end with PRIL, P-R-I-L. Thrombolytic versus anticoagulant versus antiplatelet. Thrombolytic must already have a clot, so you're going to want to give that to a patient like who you suspect maybe had a stroke. Anticoagulant such as Coumadin or warfarin, and an antiplatelet like aspirin, they prevent clots. If the levels are off, you're going to see lots of bruising. With Coumadin, you're going to want to monitor your PTINR. With heparin, you're going to want to watch PTT and APTT. The antidote for heparin is protamine sulfate. The antidote for Coumadin is vitamin K. And remember, the oral vitamin K takes longer. It takes 24 to 48 hours to kick in, so you might want to give the shot instead. Cardio-selective, that goes to the heart. Non-cardio selective goes to heart and lungs. For example, propranolol, which I'm pretty sure I mentioned earlier. What is a dysrhythmia? Dysrhythmia is basically just an abnormal heart rate, SVT, etc. You're going to want to give adenosine / adenocard. You're going to know it's working by normal sinus rhythm. Anti-hyperlipidemic, I'm not sure if I'm saying that right. That's for high cholesterol. You're going to want to watch your levels, check your HDL, which is your good cholesterol, and your LDL, which is bad cholesterol. You're going to want to treat this with statin drugs, such as Lipitor. This causes rhabdo something. I'm not sure what the word is. I just put ... But basically it's muscle weakness. So if your patient has leg pain or muscle weakness, talk to your doctor about it, or his doctor. You're going to want to take these before bed because cholesterol is highest at night. GI disorders, some non-pharmaceutical ways to treat nausea and vomiting would be the BRAT diet, bananas, rice, applesauce, and toast. Give them bland food, flat soda, crackers. An anti-emetic drug commonly used during chemo and pregnancy would be Zofran. You're going to want to give Zofran 30 minutes before chemo. How to treat H. pylori, which cause peptic ulcers. Pepsin, Flagyl, amoxicillin, omeprazole. Be careful with your laxative and antidiarrheal drugs because they can cause dependency. Lamodal has atropine in it. It will dry you up. I think that's an anticholinergic. So it's going to dry you up real good. Your patient with liver disease, like sclerosis of the liver, they could be confused or combative. Treat them with lactulose. It's going to clean everything out. It's going to clean out the toxins. It's going to clean you out. Carafate. Teach your patients, they're going to take it 30 minutes before meals, so 3 times a day, and once before bed, so technically 4 times a day. And coat your esophagus, and watch for constipation. And my last one on here is, your patient had a possible stroke. The first thing you're going to want to do is have them do the smile and frown test, assess them, and then give us a thrombolytic such as alteplase or TPA. Okay, well that's that. Good night, guys.